So I'm Antoinette Botma. I'm a rehab physician. I work in the spina bifida service and the spinal cord service, and Megan Rozos works as the clinical nurse consultant in the spina bifida service. So we...
Sound coming back here.
Don't know.
Can you stand closer to the mic?
Try. No. Well, is this better? You've pulled it up again. Okay, so we work in the spina bifida service and we manage the software problems there.
Stick to that one.
Yeah, I'll stick to this one. Right. So the conditions that we manage in the spina bifida service are obviously spina bifida, but also other neural tube defects such as sacral agenesis and conditions associated with the acronym VACTOR, also often kids with a tethered cord or with some hardware problems, as in some abnormal anatomy. We also manage kids with acquired spinal conditions in the spinal cord injury service. So that's kids with spinal trauma, inflammatory conditions such as transverse myelitis, and kids with Guillain-Barré syndrome, but also kids who've had infections to the spinal cord and subsequently dysfunction of the spinal cord, or some direct trauma to it as a result of bony deformities, tumours and bleeds. So this is what a lumbar myelomeningocele lesion looks like. So this is the most common form of spina bifida. And obviously with the nerve tissue in the sac, you can imagine that that area is likely going to not function well and will cause the software problems. So in terms of normal bladder function, Arnie already touched on this. There's two phases. The bladder is meant to fill and store the urine, and then at some point, when it's socially acceptable, you want to empty your bladder. And if there is uninterrupted pathways, normal software, from the brain to the bladder, you have normal bladder function. And what normally happens is your bladder sort of fills quite slowly. At a certain volume, you might get a first sensation to void, but you would still be able to hold on. And at some point, when you reach sort of maximum capacity, you get a real desire to want to void, and you will try and find a toilet where you will empty your bladder, and your bladder will be empty and start filling again. So that's the normal cycle. In kids with a neurogenic bladder, obviously that does not work because their nerve supply is disrupted. Their anatomy is usually normal, although in about 10% of kids with spina bifida, there may also be some abnormal anatomy. So it's a bladder sphincter dysfunction, DSD. Unfortunately, to predict this, either when we see the parents antenatally or when we've just met the babies, from the level of their lesion, or even from the type of injury later in life, it is quite difficult to predict what kind of problems they might encounter. It's quite poorly correlated, and therefore we often use a functional classification that Arnie already touched on. These are, this slide's a bit busy, but these are the sort of combinations that you can find. Combination of an overactive bladder, so quite pushy, small capacity bladder with an overactive sphincter obviously will lead to kidney damage because there's hardly any storage capacity and there's nowhere it can go other than back to the kidneys. And then there's the overactive bladder with an underactive sphincter, so these are the kids with small capacity bladders that are always leaky. And then, there's different combinations possible up to the very leaky bladders. So the overactive spastic bladder is the bladder that Arnie sort of touched on, as in that's the most common bladder that we would see in a spinal cord injury or in a kid with spina bifida. And so their bladders would normally be quite thick-walled, small capacity compared to a normal bladder that is nice and smooth-walled. And there's tuberculation with diverticular. So on IVPs, this is what a bladder would look like. And obviously, because it may push the urine back, you see the ureter and the calyces here dilated as well. A flaccid bladder, so a bladder that's very low-toned and will hold on too much urine compared to a normal bladder, will sometimes be visible on an MRI when we do MRIs of kids, and this is what that would look like. So the consequences if these bladder issues are not managed are either incomplete bladder emptying, so the children will get repetitive urinary tract infections because urine stays behind in the bladder, there may be some bacteria there, and they have a nice opportunity to multiply. The other problem can be high pressures as a result of the bladder being overfilled or spastic and pushing it back to the kidneys, the reflux. So both infections and reflux in the end will lead to renal scarring and renal failure. And in the past, when we did not know how to manage these bladders, this would be the most common cause of death for kids or adults with spina bifida. So when we first see children with spina bifida, and that's usually in the first day or two of life, we physically examine them and check what their bladder sort of habits are. We ask the nursing staff what their sort of voiding patterns are. So is this a child that dribbles? Is this a child that needs help with emptying their bladder? The nursing staff on our Gray's neonatology ward call that milking. And whether we can actually feel the bladder or not, that's obviously a giveaway that the child may get into trouble quite quickly. Another sort of giveaway is their anal tone. If they have a patulous anus, they'll likely also not have great sphincter tone of their bladder. But if they have a good anal tone, obviously they again are at risk of probably having good sphincter tone, and we might have to do our imaging a bit earlier. And the imaging is usually a renal ultrasound, because we can do that quite quickly. And that will be confirming whether they've actually got normal anatomy. So do they have two kidneys? Are the kidneys in the right spot? And about 10% of our kids, or 20 times more than normal, there will be an abnormal kidney, say a pelvically located kidney or a horseshoe-type kidney. But also the renal ultrasound will tell us if the child will be a good emptier, because often the renal ultrasound suite will be a bit cool, the child might void, and it will give us an idea of, the residue. Sometimes we find that there's quite large bladders. Arnie touched on the volume, the formula that you can use to sort of calculate the expected volume, and if we see quite a large bladder, then again, the renal ultrasound is used by us as an argument to explain to the parents that these children will have to be commenced on some active management. The other investigation that we perform is a micturating cystourethrogram. So that's more a functional test to see whether there is reflux and whether the child actually, once the catheter is removed after the dye is instilled, whether the child will empty completely. Sometime during the first year of life, we would also want to do a DMSA scan, which will be a baseline to compare future scans with, because at that stage the children likely will not have had any urinary tract infections or any pressures on their kidneys, so we would expect normal function and no scars. But if over time they would have multiple infections or ultrasound findings that suggest that there's been a lot of pressure, we would want to check for scars, because if there are scars, obviously our management will have to be a bit more aggressive. So most of our kids will have yearly renal ultrasounds to track on their development and also to check for compliance. And if there's been a lot of trouble with infections or with scarring on DMSA scans, we would start to check for creatinine and urea. And children that have had bladder augments will have to have further blood tests to check for their B12 and folate. Other investigations that Arnie mentioned are done when there's risk of kidney failure. So high pressure bladders will have more regular DMSA scans every 2 to 3 years. And if we are unable to get them in a sort of safe program, we'll usually ask our friends in the urology department to organise for urodynamic studies, because that will guide us with regards to either surgical intervention, intravesical botulinum toxin injections, that type of treatment. So hydronephrosis, most of you will know what it might look like. It's dilatation of the ureter, and depending on how high up the dilatation extends, if it's into the calyces, then obviously the grading's higher, so this is what it would normally look like. And there is a grading system. If we already at the first micturating cystogram see types 4s or 5s, obviously we'll have to be quite aggressive with our treatment. Also, when DMSA scans show scars that are sort of moth-eaten, we really want to get on top of these programs, because our main goal is to prevent renal failure in addition to social continence. So the goals for neurogenic bladder management are obviously regular emptying, preventing infections and therefore preventing renal failure and achieving social continence. And certainly in our kids with spina bifida who have very poor sensation and are very much at risk because many of them do sit all day of skin compromise. And obviously because there is a software problem with these kids, we have to make clear to the parents that despite all our attempts to get these goals happening, that toilet training, as in getting true continence happening, is usually not able with kids with this type of neural tube defect. So during our follow-up assessments, what do we check for? When they have had their renal ultrasound, we want to check if after the catheters they've got less than 10% of the volume that they started with as a residue, because that will give us an idea that they're actually doing a good job. If the residue is too large, obviously they will have not taken their time. They might need a larger size catheter to drain it quicker, or they might just need to take more time in general. And most of the kids don't want to take time out of their school life or out of their recess time. So if we see large residues, it's often something for Megan to do a bit more education with the kids and the parents. We tend to use a slightly different formula than Petrina and Arnie. And I know that Angus Alexander is one of the urologists in our service. He was trained in South Africa. He's got his own formula, but they usually end up at near the same volumes. Just trying to think. More than 70% of our kids with neural tube defects, however, do have trouble with either emptying their bladder or have had upper tract changes on imaging, and most of them would have commenced catheterization programs by the age of 3 to 4. We normally try to introduce those at a younger age because kids will accept it more easily. Introducing it at the age of 2 when you start to notice abnormal findings on imaging is quite a difficult age because they will resist it, and Megan will have quite difficult times getting the parents to introduce it. But certainly we want kids in good programs before they start school. So the ultrasounds are used to sort of guide us there. In addition to that, we will check for bladder pressures, whether they're normal or not, with urodynamic studies in kids that have had upper tract changes, and blood pressure is also measured as a sort of guide to sort of see how aggressive we have to be. In addition to getting continent and to prevent renal scarring, we also want to prevent infections and stone formation. And this means that we have to educate the parents that their bladders would respond to treatment not as great as a non-neurogenic bladder. And this is something that is important because when they go to their GP as their first point of call, they will get a regular course, and that's usually a 3 or 4 day course. And then before you know it, they have another infection, and before you know it, they get resistant bugs. So neurogenic bladders will require longer courses of treatment, usually 10-day course to eradicate all the bacteria. And if they are very prone to infections, obviously we'll have to look at different causes, so constipation being the main one, and sometimes just improving their bowel flora by using things like Inhaled and Yakult can be helpful. Cranberries can be useful. There's not a lot of evidence, but some of our kids and young adults do seem to have benefit from cranberries. So if we check the kids for their bladder health, seeing the bladder and the bowel as a sort of one whole is important. Over time, as I mentioned, we've learned a lot more on how to manage these bladders. So in the past, before the development of catheters, most clients would have repetitive urinary tract infections and in the end would get renal failure. And clean intermittent catheterization was an invention in the early 70s, and better sort of investigations to know how badly managed or what risks patients were under with urodynamic studies in the sort of late 70s was also quite helpful. I'll just go quickly through this one. So urodynamic studies, I think Arnie already showed it a little bit, but this is what we do to our kids when they go into the urodynamic suite. So lots of catheters are attached to their private parts. So we will only use this if we really need it to sort of guide our treatment. We don't tend to use it as a regular annual assessment, which in the United States, for example, it's used quite a lot more often, but we tend to use it if we really are stuck with our management because it's quite invasive. And these are the things that we would look for. So on the left, you see a normal sort of bladder behavior. So the bladder fills, and at some point, pressures start to rise. The detrusor pressure sort of increases when the child voids, and at the same time, the sphincter relaxes. So this is nice fine-tuning, they work in collaboration. In a child with a neurogenic bladder with dyssynergia, you would see the bladder starting to sort of push the wee out when the sphincter is not relaxing, and obviously that is going to cause problems in the long run. Not sure if you want to go and take over here.
Management, sure. So as my role as the nurse in the spina bifida unit, one of my goals is to get kids on a catheter program if needed. And as Antoinette mentioned before, about 70% of our kids are going to need them by the age of 3. I'd love to start all newborn babies on catheters because unfortunately it is a lot easier at this time to get the parents on board and the child on board, and they will accept it easier. Unfortunately, our kids start to show problems at about 3 years of age, and trying to get a child to lay down to change a nappy is hard enough, let alone trying to do a catheter at the same time. So the catheter program, it's really difficult for the families to take on. They see it as invasive and a big problem. But through education and support, which my role gives me the chance to do, we do have a lot of success and gain a good response from the kids. The main reason why we start catheters is to protect their systems, but also to give them social continence. My biggest goal is to get our kids in a routine and relatively dry by the time they start school. There's nothing worse than kids starting school and they're in nappies, and we all know that teasing and things like that can happen quite early on. So the 2 reasons why we do catheters, we've either got children with a leaky bladder and those who have a really tight sphincter and therefore do not empty their bladder at all. So the leaky bladder kids are probably a little bit harder to get full continence from, but at least they could be managed with a pad or some underwear that Bonds and Connie and things like that have sort of managed to bring in, that they look like normal underwear, but they can hold up to 300 mils of urine. So for a child with a leaky bladder, which I'll talk about first, we sort of just do catheters 3 to 4 hours in between each other, with the introduction of a ditropan tablet or an oxytrol patch are our first choice of medication. And that is to sort of, relax the bladder, so therefore it's not pushing as much, and hopefully we can stop the leaking. The kids with the leaky bladder could also benefit from some Botox into the sphincter neck, which might just help close it off a little bit, we hope. We're sort of open to a lot of, and things change with our kids all the time. 1 minute we're on one routine, the next we're on a different one, and that's a bit hard for the families, but at least my role's there to support them. The other kids with the tight sphincter, their biggest problem is that they don't empty, so their bladders fill up, and then you see all the hydronephrosis, and we see those results on ultrasound. So the reason why we do catheters is to empty their bladder completely, to get rid of bugs, to take the pressure off. It's a catheter that's not left in, so I think there's a lot of, people think it's an IDC that we use for kids, which we don't. It's a catheter that we just pop in, take out, and the kids are free to play for 3 to 4 hours afterwards. It doesn't take much of the time to do it once all the families are in a good routine. I go into preschools and schools and train teachers' aides in doing it. Which I was a preschool teacher before I was a nurse, and I think if somebody asked me years ago to do a catheter on a child, I think I would have found that really difficult. The other options that we do have, which we do tend to use when kids, I guess, are reaching adulthood, and it depends a lot on their mobility and how much sort of cognitive ability that they have as well. They can go to a suprapubic catheter, which we don't use very often, and you do have your indwelling catheter with the leg bag, which does tend to be more of an adult scenario, not so much kids. We try and hold off on that as long as we possibly can. For families that just cannot manage the catheters, whether it's child's behaviour or their own perceptions and their just own management plans, we do have the surgical options. So we've got the vesicostomy, which I didn't miss. We've talked about those. No?
Pictures.
Oh, there are pictures. I'm computer illiterate, you see.
So these are the regular
Oh,
catheters
right, okay.
that's Megan's normal world, and you've gone over this a bit.
Yeah.
And you've mentioned some of the medications that we use, and Arnie's mentioned them as well.
Yeah.
So the patches and oxybutynin. All of those are actually not officially registered for kids, and so they're sort of off-label, but they are tolerated well in our experience. And then the botulinum toxin injections is something that, if children do not tolerate the oral medications, can be quite useful, but not on in children under 4. It tends to not be quite successful there. Just going to go to the little pictures.
Thanks.
The vesicostomy.
So we've got the vesicostomy here, which is where they just sort of attach the bladder to the outside of the skin, maybe through the belly button, if not sort of on either side of it, just depends on where the bladder sits. This is it just leaks. So we don't catheterize that very often. It's great for younger children, about that sort of 2 to 4, if not older age group. And it's just so they'll still wear nappies and still wear a pad usually over the top as well, and it just leaks. So it takes the pressure off. Some of the kids may occasionally leak urethral, but often they sort of close that system off as well. It's not a permanent solution, which is great. So we can often close this at a later date when the child themselves may be ready to take on catheters. I did a child a year ago who was 10, and he had a vesicostomy that would just leak, and he had a bag on it. And he just said to his mum one day, I don't want this anymore. I want to learn how to do catheters. And it probably took us about 2 to 3 months of him just doing it all himself. He's now had his vesicostomy closed, he's continent, and he does his own catheters. So he was a really good triumph. So that works well, but again, it's something that can be reversed. But children with that will still need to wear some sort of protective underwear and things like that to keep it organised. Do you want to talk about the metrophonoph?
Yeah, so I'm just going to go back where we came from. So the surgical options are often used if intermittent catheterization for whatever reason is not an option. So vesicostomy is usually as an acute sort of intervention when there's really high pressures and parents can't catheterize, or kids have, intact sensation, and there's no way that we could do that. When the children are a bit older and they want to do their own catheters, but for physical reasons, sometimes because of scoliosis or because they are not very good at transferring, they might not be able to do their catheterization per urethra. There is the option of a metrophonoph appendicovesicostomy. So I'm just going to try and... So this is what it would look like. What the urologist basically does is stitch the appendix between the bladder and the belly button, so it's a continent channel because of the way they stitch it through the trusor muscle. It sort of doesn't leak, or is not meant to leak, but it's easily passable with a catheter. So obviously kids do not have to undress themselves in the same way as when they would do catheterization per urethra. So it's a lot more friendly for teenagers who don't want to take too much time out of their either school time, or if they go on outings and there's no accessible toilets. That's a great sort of invention, but obviously it is an intervention that has its risks and contraindications. For example, if someone's quite chubby or obese, and most of our kids in wheelchairs tend to become a little bit obese because they can't burn their calories off. You only have a certain length of the appendix, and kids need to therefore be on the lighter side for it to be able to be done. Sometimes an appendicovesicostomy with the use of a ureter is done if there is no umbilicus, and this is not a very common thing, but obviously it is an option. Another surgical intervention when there's lots of pressures on on kidneys because the bladder is quite small, is making the bladder a larger tank to store more urine. So using a segment of bowel to enlarge it is done with the bladder augmentation. And obviously you're marrying up two different organ systems. The bowel will make mucus, and that can lead to clouding of the urine, so the parents will have to be educated that that's actually not a sign of an infection. It can also lead to obstruction of the catheter, so they have to be mindful that sometimes they need to do a bit of a flush out of their bladder to keep going. So those are the surgical sort of options. So bladder augments have their advantages. You've got larger storage capacity. Often, therefore, they can stop their medications that they previously might have had lots of side effects from. It definitely reduces hydronephrosis chances and provides a way of continence, but the mucus, chances of infection, higher risk of stones, GI malabsorption because you're taking away bowel, and the chance for perforation. If they forget to do their catheters, obviously you've got this big suture line that they can perforate through, and over time there is also risk of malignancy because you're marrying up two organ systems, so they will have to have yearly cystoscopies to check for that, and that's usually something that we start doing immediately after they've had their surgery, although the risk of malignancy is usually not before they're 10 years down the track. Infection management, as we said, many of our kids, because of the way their bladder doesn't empty well and because they're on a catheter program, will have bacteria in their urine. And if they present to their GP or paediatrician and they say, I've got fever, I'm not feeling too well, most people would send off a urine sample. And then when it comes back with some bacteria, people might think, okay, yeah, we found a cause for their fevers, they have a UTI. Well, unfortunately, in about 70% of patients who are on clean intermittent catheterization programs, you will find bacteria, and by itself it's not proof that someone actually has a urinary tract infection and that is the cause for their fevers. So we would define a urinary tract infection in someone who's on clean intermittent catheters or who has a neurogenic bladder as the presence of physical symptoms, and that could be, for example, someone's always been dry between their catheters on a catheter program and they all of a sudden start to leak, or they might feel a stinging sensation when they pass their catheter, whereas normally because of their lack of sensation they would not actually feel it. Obviously some vague sort of abdominal pains, sometimes headaches. Those could be all physical symptoms in addition to obviously fevers and vomiting. And then in addition to the physical symptoms, you would want to find pyuria. So you will find up to 10 white blood cells in a urine sample in someone who's on catheter. So again, that's not proof, but really more than 100 white cells is what you would want to see. And then obviously the bacteria. And as we said before, they do not eradicate as quickly as a normal bladder. So once you've decided that it is a symptomatic urinary tract infection, you would want to treat them for at least 7 to 10 days. And then there's not a great deal of point of checking a urine sample afterwards if they are not symptomatic anymore, because again, you will find bacteria in a child on catheters. If the urinary tract infections are not managed well, we've found that a number of predominantly teenage boys present with epididymitis or epididymyoclitis, and that is often something that is a bit of a flag for us to say, okay, they've probably had lots of infections that were not treated sufficiently. So I think that would be one of our takeaway messages for today, that neurogenic bladders, they behave different, but they should also be treated differently. And in case someone, doesn't know what to do, we're always happy to get phone calls or emails, because many of our kids would present to ED here or to their general paediatrician or to their GP, and we try to educate the parents that, this is different, and most people in the community are not very experienced because it is a rare condition, a neurogenic bladder, so they might not have that knowledge. So just call us.
Yes.
These are our contact details. Done. Thank you.